Hi, and welcome everyone. I am Jennifer Boyle, and I'm the team lead at the Center for Communication Programs, supporting activities implemented in Malawi under Breakthrough Action. Today's webinar, Encouraging Family Planning Counseling that Promotes Meaningful Choice, is presented by Breakthrough Action, USAID's flagship global program on social and behavior change. Breakthrough Action ignites collective action and encourages people to adopt healthier behaviors by forging, testing, and scaling up the new and hybrid approaches to SBC. The goal of the Breakthrough Action activity in Malawi was to improve family planning outcomes for postpartum women by designing scalable interventions to change provider behaviors in Malawi using a behavioral science-based approach. Breakthrough Action's activity partners in Malawi included the Ministry of Health Reproductive Health Directorate and Organized Network of Services for Everyone's Health, ONSE, implemented by Management Sciences for Health and the College of Medicine. In this webinar, you will hear from Ely McElwee and Abigail Sellman. Both are senior associates at Ideas 42, a partner in Breakthrough Action. You will also hear from Dr. Phoya, the Principal Technical Advisor at MSH in Malawi. Her colleague George Maruwo, the FP Technical Advisor, will join us for the Q&A session. The presentation will be around 40 minutes with 20 minutes for questions. During the presentation, you can ask questions in the chat at any point. Your questions will either be answered immediately via chat or saved until the Q&A. And with that, I will pass it off to Ely to begin.
Thank you so much, Anne. And again, welcome everybody, and thank you for being with us today, either in the morning or in the afternoon, evening for some people. So today I will start with a brief project background, then I will really dive into our behaviorally designed solution set. Finally, I'll pass it off to Abby Sellman to talk about the evaluation and results, and then Dr. Phoya will talk about our implementation insights, followed by our 20-minute Q&A. And again, please drop any questions in the chat whenever they come up. We'll save them for the Q&A. So this activity in Malawi started in 2018 and focused on family planning uptake for postpartum women in the districts of Lilongwe and Machinga. As you can see here, our behavioral problem was identified through formative research. This included interviews with family planning providers, interviews with family planning clients, observations at health facilities, and also interviews with stakeholders in Malawi. And through these conversations, we landed on the problem statement of providers aren't delivering family planning counseling to postpartum women on all methods, or discussing all possible times for take-up in a way that empowers women to make an informed choice. And we worked on this problem statement with our partners at ONSE Health, who have joined us on the call today, as well as with the Malawi mission. So let's first look at, why does this problem statement matter? So I'll ask you all a question via poll to see what you know about unmet need in Malawi. And let me know if you can see the poll. There it is. So according to the Malawi DHS in 2015 to 2016, what is the percentage of unmet need among married women in Malawi? So I'll give you all time to answer. All right, so it looks like a lot of people were thinking 38%. So let's see if we got it right. So it's actually 19% is the unmet need. And so this is the unmet need amongst married women. So I'm sure some people were thinking about unmarried women, or maybe women who were not included in the survey. So this is a percentage of women who are just not receiving, or currently don't want to have a child, but aren't taking any actions to prevent pregnancy using a modern contraceptive method. So within the women in Malawi who are using a family planning method, 60% of them are using a short-term method. These include condoms, pills, and injectables. And these methods have high discontinuation rates. So to look at those discontinuation rates, we have another poll. So according to Malawi DHS 2015-2016, what are the 12-month discontinuation rates for injectables and pills in Malawi? So you can see injectables first, followed by the pills. So choose which one you think is the correct answer there. Perfect, there we go. So people have identified the injectables at 41% and the pills at 62%. So collectively, you guys did a great job. This is the correct answer. So over the years, over a 12-month period, injectables do have a continuation rate of 41%, while the pills have one of 62%. And so why might women discontinue? Some women likely want to get pregnant, so have decided to stop for that. But maybe other women have made a choice about their family planning method that wasn't fully aligned with their family planning needs. So for this, we come into our behaviorally designed solution set. This solution set addresses our problem to promote behavior change with providers and encourage family planning counseling that promotes a meaningful choice. So here are our final solutions. We designed an antenatal care handout, a postpartum family planning reference guide, a group counseling tool, and a method referral card with a drop box. So we conducted these interviews through diagnosis and looked at provider-side barriers to family planning uptake and continuation for postpartum women. The solution set addresses these barriers, and after we designed them, we went through multiple rounds of user testing. So we took prototypes, brought them out to the fields in Malawi, and asked both women and health providers what they thought of the designs and how they would change, and saw how they really used these solutions before finalizing them. And all of these solutions are to be implemented following a values clarification workshop. So I'll go now deeper into each solution set. And just to flag now, all of these solutions are freely available on the Breakthrough Malawi website, which we'll share at the end of this presentation. So our first solutions are the antenatal care handout and the postpartum family planning reference guide, which you can see here. These are used during antenatal visits. And in Malawi, women come to these antenatal visits with a health passport. So we designed this, see if I can get this antenatal care handout to be a sticker that was inserted into a woman's passport. All of these designs are also available in Chichewa. And for the antenatal handout, we made it in black and white. So maybe one day the Ministry of Health could print it directly into the health passport, thus making it less expensive to scale. And so here you see the family planning reference guide, which is used for mothers who are currently breastfeeding and is a laminated card that stays with the health providers. So let's first look at the ANC handout in more detail. So providers are very busy and they have a lot of topics to cover during ANC. So that can lead them to not discuss family planning until after the baby is born. This could mean that women aren't fully counseled on their family planning choices before their baby is born. So we use the antenatal handout and the first part of it to really help reminders to remember to start talking about family planning early and discussing family planning with women during ANC. And this design is also a visual for women to help her think about all her methods. Using these pictures, the midwives or doctors or nurses can talk with the woman about their methods, and they get to bring this insert home with them. All providers, and not just ANC providers, defaulted to talking about family planning at 6 weeks. This led pregnant women to not learn about their options or really have time to consider their options for 6 weeks, missing opportunities for things like immediate postpartum family planning. So the second half of the handout is designed to discuss the timings and link these timings to the baby's development or times when the woman might be already coming back to the health facility. So this design helps women make a plan for when to take up family planning postpartum. And so either with a health provider or at home, she can decide when does she want to take up family planning. I think Dr. Ann, if you could mute, I'm getting feedback, thank you. And so she can just check the box when she's interested, including other, which is maybe she doesn't know yet or she doesn't want to use family planning postpartum. And this is in her health passport, so any provider is able to see what she decided. So next we have the reference guide, and providers again reported that 6 weeks postpartum was really when they thought women could start family planning. So this led again to women not really having a moment to consider family planning during pregnancy or learn about all their options for timing of uptake. So we designed this postpartum family planning reference guide so providers can easily discuss when each method can be started postpartum. Oops. And as you can see, it's got visual cues that really shows that there are a lot of methods available before 6 weeks. So these visuals show providers that indeed there are methods a woman can take up before 6 weeks, as well as the methods that become available to her after 6 weeks. So next we'll look at the group counseling tool. This is a poster, a very large poster or a mat that can be hung up at a health facility or laid on the ground. And this is what it looks like when the health talk starts. Everything is covered. It's just kind of showing numbers and colors. And the poster comes with a 6-sided die that matches the colors on the poster, as well as 10 counseling cards. And these 10 counseling cards include 4 introduction cards that tell women how the tool works and help the provider explain the tool, as well as has introductions about family planning, talking about why a woman might want to consider using family planning, a small discussion about side effects, but that really directs women to talk about side effects during one-on-one counseling. And so let's take a look at some of the details of this tool. So providers were seen to present a lot of bias during their group counseling. They were very varied in the information they shared. They would talk about certain methods over others, or they would maybe counsel heavier on the methods they thought women would really take up, like Depo-Provera. And this resulted in an intermingling with women's biases of maybe wanting to use methods they've really already heard about from friends and families. And it really prevented women from really learning new information during the counseling. So we designed this group counseling tool to help providers give women information in a way the woman can internalize. So this tool works by the providers presenting the tool. It's covered in the beginning. They ask for a volunteer to roll this dice. And once the dice is rolled, the color that corresponds is the color of the card that the provider reads. So the provider reads the purple information on the purple card, and then before revealing the method, pauses to ask the woman, which method am I talking about? And so by making the methods revealed in a random order, we're taking out some of the bias that both providers and women have, but we're also revealing the method after information is shared to maybe keep women a little bit more open to listening about methods she'd already ruled out for herself. Like if a woman thinks an IUD is not for her, she might just say, when a health provider says, okay, we'll talk about IUD now, she stops listening. But if she gets the information first and is then told it's IUD, it might help open her mind a little bit, if she's interested, of course. And finally, in the counseling, we saw that providers shared incompatible information on the different methods, varying the focus on side effects, administration, duration, medical eligibility, and giving different information for each method. This led to a lot of information overload and didn't really help the woman focus on just a few aspects of each method to allow her to compare across methods. So in the counseling tool, we have pictures after they're all revealed. There's pictures of every method, along with a couple of symbols that indicate some categories that we saw women were more interested in during their interviews. So and the categories that we identified for them were the return to fertility using this pregnant woman, and the things a woman must remember in order to use the method and keep it effectively. And with these 2 categories, we also instituted a stoplight coloring to help women think about if this method is right for her, if she's interested in that category. So if a woman wants to return to fertility quickly, maybe green shows that the pill could be good for her because she could return to fertility quickly, but maybe she wants to consider, if she's thinking about Depo, she needs to think about it, that her fertility could be kind of unknown, how quickly she return, maybe 3 months, maybe more. And the same with things she must remember, like for the injectable, she has to come back every 3 months. That's a bit of a hassle, but for the pill, she needs to take it every single day. So that's important to her to not have to do that. She might not want to consider the pill. So we'll do a quick demonstration of how this tool works in action. So I want you to imagine you're a postpartum woman sitting in a health facility in Lilongwe, and the nurse gathers you around. She tells you she's going to share information about different family planning methods. And once the group picks the color, she'll read information about the method she wants. So if you can all use the poll to say which color you'd like to use, we have purple, pink, orange, blue, gray, or green. And I'll choose whichever one is chosen. And down here you can see that this is where the two items are on like a key on the thing. So we all chose purple. Okay, so let me click, oh my gosh, move this. Let's see what purple says. You can have your next baby whenever you're ready, in a short time or a long time. When you want to have a baby, you can get pregnant right after you have the method removed by a trained provider. There is no charge to have the method removed. You must only come to the clinic one time to get the method, and then you're protected against pregnancy for up to 10 years, or whenever you decide to stop using the method. Which family planning method is this? I have another poll so you can respond to which method you think it is. So is this the IUD, the implant, permanent method, injectable, pills, or condoms? Well, the IUD, oh, you're very smart. I'm the one that said condoms, so if anyone's worried about that 2%. Very good. So this is some information the woman would see, and then the method would get revealed. And this is what the poster looks like after all the methods are revealed. The talk takes about 25 minutes in total, and it can be left hanging or laid out at the health facility afterwards. Finally, we come to the method referral card and Dropbox. This is a small card about the size of a woman's health passport that we printed on cardstock so health workers can write on it in these spaces. So let's look at a couple of features of this card. So providers have adapted to go fast and see patients very quickly in health facilities. So they frequently miss discussing women's individual needs. This leads to women never being given time to consider if they're really happy with their methods. So we designed this referral card to give the woman some time and to help the provider talk to her about satisfaction. So you can see this design asks the woman to consider her choices and gives her a picture of all the methods. So she can look at them there, but she can also bring this home and think about the methods at home and talk with anyone she thinks should be involved in her decision. And this also takes pressure to switch in the moment or to decide for a woman to decide on which method she wants in that moment. So it kind of takes the woman and the provider, takes the pressure off them to choose and switch on the spot. And so also when women are thinking about their right method, sometimes they choose a method and it's unavailable, and providers give them different responses. They either tell them to come back later, they give them a short-term method and say they can change later, or they kind of convince them to use a method that is available that day. And this leads to women's needs not being met. And some might come back or some might not, or some might just say that they'll keep the method they received that day and not really think about if they're satisfied or not. So the second part of the card allows health providers to help women plan to actually get the method of their choice. If that provider can't give that method, maybe they can give her a short-term method and tell her the date of expiry to come back. And they also tell her where to come back. So if they should come back to the facility, if they should go to a certain provider, or maybe they should go to another organization. So this card is important to really have strong public-private partnerships. So say if Labanja with MSI can give the permanent methods, but the health facility can't, the public sector can refer to the private sector. And finally, after a woman gets the method of her choice using this card, she leaves a referral card in the Dropbox at the clinic, showing the health provider that the woman did indeed follow up, and kind of closes that loop and lets the provider know it was a valuable thing to do. And that is all the tools for now. We can of course discuss them more in detail, but I will pass it off to Abby.
Thanks so much, Ellie. So now I'm going to share a little bit about results from 2 evaluations that we ran on the solutions.
Sorry, my pointer's stuck.
So we ran 2 small studies to evaluate the solutions. The first study we ran was based in facilities, and it was a 3-week feasibility study where we were trying to understand the operational feasibility of the solutions, how they were working in practice, what things providers liked about them, what things could be improved. And then after that study, we ran a 3-month pre-post evaluation to assess the feasibility of the solutions and also to understand the potential for impact of the solutions. In the second study, we were originally planning to run a randomized evaluation also in health facilities, but unfortunately our study was set to begin at the beginning of March last year, so we had to change our plans because of the coronavirus. So what we ended up doing was just running a pre-post evaluation and also implementing the solutions in the communities rather than in facilities. We implemented in communities mainly because we didn't want to overburden health facilities with new tools. And also this was helpful because it allowed us to understand whether or not the solutions would also be impactful when working in communities and how they would be feasible for the communities. We also adapted some of the tools because of working in communities. So for example, the group counseling tool, we again, because it was the beginning of coronavirus, we didn't want to encourage group counseling at that time. So we adapted the solution so that it could be used for one-on-one counseling, but so that it could support all of the behavioral elements as the group counseling tool. We also discarded the antenatal care insert for our second evaluation because antenatal care wasn't provided in the communities. You can go to the next slide now, thank you. So the research questions we explored in our pre-post evaluation, all of our data collection was done with providers, and the research questions were in 3 themes. The first theme was around provider behavior change. The second theme was questions around providers' knowledge, specifically their knowledge of postpartum family planning, timing of method uptake, and immediate postpartum family planning. And the third bucket of questions we asked were around provider attitudes, primarily around provider attitudes towards method switching and whether or not it was appropriate for women to change methods and how that process would work. The first key takeaway from our evaluation was that providers in the study were more likely to give women referrals for family planning. From baseline to endline, the percentage of providers who reported that they had given a woman a referral for family planning in the previous 2 weeks increased by 34 percentage points. The second key takeaway was that providers' knowledge about postpartum family planning also improved. So from baseline to endline, the percentage of providers who know that postpartum family planning can be delivered immediately or within 48 hours increased by 34 percentage points. So while at baseline, only 63% of providers knew that postpartum family planning could be delivered within the 48-hour window after delivery, at endline, 97% of providers knew that. And in general, providers had more knowledge about when certain methods could be delivered in the postpartum period. So we asked providers, when can a particular method be taken up? And they were much more likely to report the correct answer at endline. Our third key takeaway was that providers were more likely to discuss switching methods with women when using the solutions. So from baseline to endline, the percentage of providers who reported that they had discussed switching methods with women in the previous 2 weeks increased by 63 percentage points. So only 32% of providers reported that they discussed switching methods with women at baseline, but at endline that was 95%. And we also found increases in the percentage of providers who said that they approved of women switching methods on the same day that the woman had come in for her consultation. And the last key takeaway from our study, and this is from the feasibility study, because as I mentioned previously, we were unfortunately unable to roll out the antenatal care handout during the evaluation. But during the feasibility study, we did see that the antenatal care handout was very promising. And specifically, we saw through our observations in the feasibility study that when providers were using the antenatal care handout, they were just as likely to discuss immediate postpartum family planning as an option for women for family planning after delivery, as they were to discuss the option of delivering family planning at 6 weeks postpartum. So if you remember from Ely's description of the solutions, the defaults that providers were discussing with women was generally telling them to take up family planning at 6 weeks. So we found the fact that providers were talking about immediate postpartum family planning as an option was promising. And with that, I can hand it over to our Malawi team and Dr. Phoya or George, if Dr. Phoya is struggling, to talk about some implementation insights from their perspective.
Thank you, Ali. Can you guys hear me?
Yes, we can hear you.
Yes, we can hear you. Okay, thank you. I'll go now on to the implementation insight. Thank you, Ely and Abigail, for the presentation. So having gone through the studies and observing the providers, these are the few implementation areas that we are recommending. And what we have noticed, first of all, is that all solutions were easy for providers to implement. And I have seen this in action in one of the health centers that I monitored this intervention. Solutions were seemingly integrated into existing processes. They didn't have to do anything different. It just became as part of their daily work when they're in the family planning clinic or in the antenatal clinic or in the labor ward. Next. The group counseling tool had a reduced workload for me. That was one of the providers giving us information on how they felt using this tool. They felt that it summarized all the information and it was easier for them to reach to all the women at once with adequate information. Other than having talking to one-to-one group counseling seemed a very easy method for them. One provider said they had gained more knowledge and skills on family planning methods, and it was easier to identify the women who have been assisted and who have not. This is through using the cards and everything that was given. Next. Providers also saw potential for the solutions in improving access to family care for the women. For example, in the antenatal card, it was quick and it was helpful at the beginning when you start a conversation about family planning and when the women are demanding it, because it was helping them to discuss with their men. If they have been given enough information during the antenatal clinic, it was easy for them to go and discuss with their men as to when to start family planning when the baby popped out. They also felt that the health talk was so enjoyable and very educative, and the women were so engaged and answered questions freely. So this was also one of the insight from the providers. Next. So we also had the interaction with the Ministry of Health, specifically the district level and also at the national level. So at the district level, this is both in Machinga and in Lilongwe. We saw that both the districts were very excited by the results and are interested in continuing and expanding the implementation, which is very good because this shows the uptake of the intervention by the owners of the districts. And they recommended that they include the solutions in their future planning for family planning. And we also saw that supervision for the solutions could be integrated into their routine supervision. For example, the family planning coordinator could include uses of these solutions when they go to supervise family planning at the health facility level. At the national level, we interacted with the reproductive health unit and the technical working group on family planning. And what we heard from them was that they have understood that the solutions have found out gaps for group counseling and liked that the solutions was going to assist complementing existing work. But also this gave them information on how the FP counseling guidelines could be looked at and probably improved upon so that counseling could be done properly for people to appreciate issues of family planning and make an informed choice. Next. The current plans that are going on, this is ONSE and the Reproductive Health Unit. We've agreed that we'll continue with limited implementations on the solutions in the study districts in Lilongwe and Machinga, because these districts have already bought into the solutions and are willing to continue with them. And then as partners, ONSE and the Ministry of Health, we plan to work with other partners in Malawi to discuss further implementation of the solutions at a larger scale. Because you remember that we've discussed these solutions and findings at the technical working group, where most of the partners that support government to implement family planning, we sit together we discuss and share lessons. So the part of the ongoing plan is to make sure that all the partners have been appraised of this solution and probably try to ask them to fund some of these activities into their ongoing work for family planning. Thank you.
All right, thank you so much, Dr. Phoya. And I will now ask if all of our presenters could show their videos so everyone can see who's talking. And we have collected a few questions and answers. People are also able to kind of unmute and say you have a question, but I will get started with questions from the chat that people sent while we're going. So you have to forgive me, I'm going back and forth on screens right now. So hopefully I can get this seamlessly. Well, since everyone has heard from myself and Abby, George, I'm gonna throw a question your way, if that is all right. So we have a question here about male engagement. So a couple people shared some studies. Thank you for sharing that study. And the question was really that they noticed that clients on the pictures were all women, and we talked about women. As Jill pointed out in the sharing of the study, men may be decision makers. We know women like injections, so their husbands don't know they are on family planning. Can you talk about how we tried any approaches with partners or are thinking around integrating partners into the use of these solutions, or even the work that ONSE is doing?
Yep. Thank you so much, Ely, and thank you for the opportunity to be on this webinar. Yes, indeed, I think male involvement in Malawi is a big issue, and rightly that the men are decision makers at household level. So I think in this study, what we managed to do is using the ANC instant card, it gave an opportunity for the women to really start engagement with their husbands, and then during the process until the woman gives birth, then they would be able to contemplate on a method that the woman could use. And there was also an option that maybe if the woman was not, the husband did not understand well what the woman had gotten at the hospital, then the man would be allowed to come to the facility, and then there would be that male involvement through the counseling sessions that were happening. And in some of the facilities, we noted that even when they were rolling the dice and using the group counseling too, some of the men were able so to take part, and that I think promoted some of the information that the men didn't have, because essentially in Malawi, I think most of the men do not go to hospital. Recently is when we are trying to implement male-friendly environments within the hospital so that they can take part. So basically, I think that's what we did, and we hope that with that engagement, then the men would make the decision for the woman to continue with the methods. Thank you.
Yes, George and the team, I would also like to supplement that response that in our antenatal clinics, men have been really encouraged to come, that when their wives are starting antenatal care, they come with them. So I've visited a number of clinics where I have seen men accompanying their women for prenatal care. So if we can get these solutions that we can implement at the antenatal clinic, definitely we will have more men that are understanding issues of family planning. But also through other partners, there is currently an ongoing message in a number of radio stations in Malawi that are promoting male involvement in family planning. So I'm hoping that if these radio messages go on, then it will supplement the activities that we do at the facility level. Thank you.
Thank you both. That was great. And I'm gonna now kind of jump us up back to data monitoring. Question from Ben Stevens was he's curious if the project collected client experience data, like the method information index, to monitor the extent to which these provider-focused tools, in fact, change the information clients received. And in tandem with that is like, did the family planning new acceptors increase as a result of this intervention? So maybe Abby, if you could talk a little bit about the data we collected around the family planning use.
Certainly, I can talk about that. So thank you for the question. And I think in an ideal world, it would have been wonderful for us to be able to monitor client outcomes and do a lot more research into how the solutions were impacting clients. Unfortunately, because as I said previously, the study was implemented right at the beginning of COVID, we weren't able to collect data from clients because of IRB restrictions. So we had to rely on our data collection with providers. So what we did is we asked providers how they thought the solutions were impacting women, if they saw any changes in women's behaviors, how they thought women were perceiving the solution. So those are some of the quotes that we shared previously. I think in the future, as I said, it would be awesome to collect some of this data. And we have been talking with the Ministry of Health and also UNSE about how we might integrate some of the outcomes we'd be interested in learning about into new registers or into monitoring and evaluation plans for continued implementation. So definitely something we're thinking about.
Great. And along the lines of data, if you could, there's a couple questions about the timing and the baseline and end line. If you could just give us a little bit of information on how long the implementation period was. To answer Davina's question, I believe Jimmy also had a question about timing of the study.
Yeah, so I can go over that quickly. So the first feasibility study was very short, just 3 weeks, so that we could assess how the solutions were working and if we wanted to improve them. Then about 3 months later, after we made changes to the solutions, was the pre-post evaluation. And that study was run for 3 months. So between baseline and end line, there was a 3-month implementation period.
Great. Thank you. And so we have a question from Claudia here about how does that I'll start to answer, and maybe George and Anne, if you can jump in afterwards to add to my answer. So asking, how does postpartum family planning address the discontinuation issue? So in these tools, we really started looking at postpartum family planning and how can we help women think about their options immediately after birth and in their to 2 years postpartum period. And so we were seeing that women started hearing about family planning at 6 weeks. So first we wanted to get them information sooner so they had time to consider all their methods and potentially really think about which method would be right for them. And if women have more time to think about the methods, we're hoping that they'll be more comfortable with the method they chose and hopefully understand the method, and in that understanding lead to less discontinuation or more satisfaction with their method. And where that referral card comes in is gives the providers a moment to talk to the woman about satisfaction and really see both if postpartum women, but if also other women are satisfied with their methods, and hopefully leading to discontinuation in that way to help with switching and to allow for that. So George, I don't know if you have any other comments about postpartum family planning linked to discontinuation.
Yes, thank you so much, Ely, and thank you for that question. Yes, I think you have addressed it, but what I would speak to is that I think the tools enable to improve the quality of the counseling because as you mentioned in the presentation, it filled a gap in terms of using the group counseling tool. In Malawi, we have a tool that is used for group counseling and then the individual counseling. So the group counseling tool has slowly died a natural death, and it's no longer sometimes available at facility level. So the group counseling tool enabled to improve the quality of counseling so that the women could get the informed, the comprehensive information and then make an informed decision about the particular method that they would take. So basically, I think that alone, minus the depot that has high discontinuation rates, then the women would have more knowledge of a particular method and then they can make a choice. I wanted to say early that Elimas is also on the call. Maybe if she might have inputs as well, she can come in.
Yes, Elimas, anything you have, please do jump in. I believe you have the power to unmute yourself.
Yes, but I think for this question, this is ably handled maybe for later questions.
Of course, thank you so much. And yeah, so looking again, I might go back to postpartum family planning actually. Davina here asked, for immediate postpartum family planning, did providers also get skills development, perhaps through partners or separate projects? It's one thing to talk about advocating postpartum family planning, and to the client, but then the providers must also get their hands-on skills reinforced, especially with LAPMs and LARCs. Yeah, exactly. We definitely agree with you in that, Davina. And this is why our project was working very closely with ONSE, who were working to train health providers, which I'll let George and Ella might speak more to. But our project did start with that values clarification workshop to start as a moment to talk about what postpartum family planning is, and ideally identifying the gaps in skills to then work with another provider like ONSE. And maybe George, if you'd want to speak to kind of the other activities in tandem that we're helping providers think about postpartum family planning.
Okay, thank you so much. So in Malawi, when we started supporting ministry under the ONSE health activity, all the health facility providers were built capacity on most of the family planning methods, especially for LACs and payment methods. So when we brought in the breakthrough action study, it was just complementing on some of the knowledge that they already had. But as mentioned earlier, in Malawi, we are reviewing the family planning preserves manual, and we have worked with the ministry to ensure that we have the insight of the immediate postpartum, because that was lacking in most of the facilities. And when we are doing this, most of the providers already have the skills to provide implants, short-term methods, and for permanent methods, there are outreach clinics that happen at the facility. So it just facilitated the knowledge on when the woman can start a method within the postpartum period. So basically, I think there were already providers that had knowledge on postpartum, save for the immediate postpartum that ONSE is planning to support ministry to roll out. But for the other postpartum period, I think the providers have the skill to provide. Thank you.
Yeah, George, and the team, I just would like to add one or two things in terms of the immediate postpartum family planning. I recall a program that I worked on before. We had trained health workers from 3 districts to do immediate postpartum family planning, especially in setting in an IUD. What the experience we had was that the midwives felt that this was an extra load of work. So probably as we continue with the solutions, we may wish to look at a solution that we can empower the midwives to see that if they were to insert a loop immediately after the baby has popped out, it may not increase their workload as they so believe for the time being. But there are people in the system that have been trained to do immediate postpartum. For example, at Area 25 here in Lilongwe, there are people that were trained in Kasungu district and also in Zomba. So there are people in the facilities that already know how to do some of these things. Thank you.
Thank you both so much.
Can I come?
Yeah.
I raised my hand.
Oh yes, please. Sorry, I can't see any other people's items, so please go. Yes.
Okay, thank you. I just wanted to add on what my colleagues have said, but then I'm relating it very well to the solutions. I think what these solutions have done is to the introduction of this family planning counseling and education in the antenatal clinic, so that the clients already know, and those that are willing can demand even when nobody has counseled them after delivery. So they already know the information. They have received this information throughout pregnancy as they were attending clinics. So that's one area which I see that these solutions are trying to address. But then again, indeed, how to provide these methods, it is mostly in the pre-service education, except for the few methods that are just coming in. So in terms of the knowledge and skills, these providers do have, especially for the nurse midwives and clinicians. But then the issue was now, how much information should I give to a client when I'm conducting this health education? So sometimes they will not feel comfortable of the quantity that they have. And the one that George referred to previously was a big, like a is it a pamphlet? Flip chart, a big flip chart. But this one is portable and with information well condensed, covering very important points that a client should get and that a provider must communicate. So these are really helping. We saw them being very helpful in the sites that we were implementing these solutions. Even the cadre that we were following up, they are low cadres. They are not like at the level of midwives or clinicians, but they were able like to even internalize that they can even teach without making reference to those solutions. So these are the strengths that I see the solutions bringing into play in SRH. Over.
Thank you, Elmase. And yeah, and I think there you raise a great point that these solution sets, we really worked to have them be something that's integrated with what's already happening in Malawi. The Ministry of Health is working hard to improve postpartum family planning. So we're trying to give them tools to kind of fill some gaps that we're seeing. And in kind of talking about one of those gaps, there's a question here around switching and how is method switching addressed in the design of the tools and training providers? Are providers trained on how to counsel women who might be interested in switching methods versus who the potential users are? So I'll pass it over to Abby to talk about how the tools kind of address switching and what we saw them doing.
Yeah, thanks, Ellie. So the primary way that the tools address switching is through the method referral card. And what the card is really designed to do is provide a moment or a tool that providers can use to have that moment of contemplation, to allow women to say, you can think about switching methods and take your time on switching methods and come back later. So it's giving providers that reminder and a tool to facilitate those discussions. And then also it helps give providers a tool to handle method switching, because when the card is brought back to the facility, it makes visible the number of women who actually do want to switch methods. So it starts showing providers that yes, women do want to switch methods. And yes, if I provide them with this moment of contemplation and enable them to come back later, they might switch methods.
Thanks. And then we have a timeline question here that I'll address a little bit, and maybe George can pass to you to talk about what's happening currently in Malawi with these solution set. So we answered the question about the timeline. So again, Davina said, we know the knowledge and skill attrition is a real issue, and that knowledge drops quite steeply after 6, 9, or 12 months later. Do we as Breakthrough Action have plans to go back to the same providers to see if the post-test data are similarly as high? So unfortunately, our timeline has ended, and we're working on the dissemination and the sharing of these tools, as well as helping our implementing partners in Malawi take these tools on. So we're really hoping that the tools can be used in an intuitive way by the providers, and in using the tools, it'll help them reinforce the knowledge that they're gaining from the tools. But George, if you want to talk about kind of how you're continuing to work with these tools and what you're seeing with the providers now.
All right, thank you so much, Ely. And you have already said that Breakthrough Action is concluding probably next month with the cost extension, no cost extension. And what, as ONCE, we are doing is we already working with Reproductive Health Directorate, who are leading the process in terms of ensuring that the tools can be disseminated further. So to do that work, we have already worked with Health Policy Plus. They assisted us to package some of the tools into an advocacy tool to Reproductive Health Director, so that Reproductive Health Director then can use it as they engage other partners. And we're working with them to ensure that in the districts that we are co-locating, then we're able to advocate for postpartum family planning using the advocacy tools that were generated. And soon, next week, we are assisting Reproductive Health Directorate to present the study findings to senior management of the Ministry of Health of Malawi. And once that, through that process, if the approval is granted, then we will continue in the districts that we started this study, and then probably expand within the districts and our reproductive health director then will engage with other partners to scale up these tools. As I said earlier on, Malawi, one of their key strategies is to promote postpartum family planning now. So I think this fits in well within the plans of Ministry of Health, and they would really want to ensure that most partners that are coming in are able also to ensure that they are within their planning, within the implementations of family planning SRH services. They have captured postpartum family planning using the tools that will promote clients to understand the methods and the misconceptions that come with contraception. So basically, I think that's what we are doing. And with the few months that we have, we really are relying on the reproductive health director to move the agenda with the other partners. But that's what we are planning, that within the facilities that are implemented, then we are going to push this up. Thank you.
Yeah, and I also would like to add that I think we have looked at the solutions and their impact in terms of the provider. I think this information has come at an opportune time. And now that reproductive health unit has managed to get time from senior management to present, I'm hoping that senior management will give us the green light that this is indeed something that we can do, because currently the reproductive health unit is in the process of finalizing their strategic plan for the next 5 years. So this is the time that if you can manage to knock on the right doors and talk to the right people, these solutions can find their way in the strategic plan that is about to be finalized. And I know that government is also in the process of developing their new plan to replace the FP 2020 that has just expired. So I'm hoping that will be another opportunity for us to include these solutions as a scale-up plan. Thank you.
Just to add on what my colleagues have said, I think as partners, we do lots of studies, implementation, but what we want to achieve in the end is that the direct beneficiary, like the department in the Ministry of Health, has to be convinced that this work is really going to help them. And I must say that in this work, we have achieved it. I can say even more than 100%, because I think RIHG has been involved at each and every stage. And I have seen the lead person for family planning, whom we've been working with, also has fallen in love with the outcome of these solutions. And even before receiving the go-ahead from the senior management, we've seen her already talking to partners to say, can you support this? Can you support this? So I see that we are at an advantage because she has an influence, talking to partners that are working on family planning. So I'm very sure that even after ONSE has phased out, she will continue to talk about postpartum family planning and how these solutions can help improve, because she really understands each and every step and what has improved. Over.
Thank you so much, everybody. Thank you for the questions. And Mary, saw your comment. We can take that into advice and follow up. But I'm going to have to just do a quick wrap up now, as we have just 3 more minutes. Thank you, everybody, for your time. So just some quick final takeaways. As you can see here, we did find that these tools were, as we stated, the tools were of interest to our online users, the health providers, and with the help of LME, Dr. Phoya, George, and other partners at ONSE, were able to start integrating with the Ministry of Health. And the providers really saw potential for impact for family planning outcomes. And finally, the solution toolkit and an implementation guide are available on the Breakthrough Action website. I shared the link in the chat. Please go there. There was a question about language, currently in Chichewa and English. We could share the Word documents with you if you reach out to us. And so you could get them translated yourself under our purview of this Breakthrough Action project. We wouldn't be able to translate to any more languages. So just real quick here, I will share our contact, and Marcella is putting up a poll if you could respond to that before you head out. And a big thank you to everyone who presented today and talked, to Marcella and May, who really helped us with the technical work on the back end. And thank you again to the USAID mission for all of your help. So yeah, we look forward to you. Reach out with any questions and have a great rest of your day or evening.